Discover KDH Collective's Leaning into Therapy podcast, an enlightening exploration of therapeutic approaches and evidence based protocols. Join us as we delve into the vast landscape of therapeutic interventions, guided by the belief that collective intelligence surpasses individual expertise. Led by Katie Holmes, a licensed professional counselor with 16 years in private practice. This series offers valuable insights, expertise, and training from a team of skilled therapists. Prepare to immerse yourself in the world of therapy, created exclusively for therapists by therapists. So, welcome back to Leaning into Therapy, where we talk about different therapy techniques, ideas, just all kinds of, which cover a lot of ground with it, continuing education. And today I have Dr. Allison Buller. Allison, do you want to tell us a little bit about yourself?
Sure. I appreciate these conversations. It gets me thinking about the field and about the work I do. I'm a professor of counseling and I'm also a practitioner at KDH. And I've been practicing, God, what, 20 years now? Has it been? A long time. And I'm learning things all the time. And so that's why I get the opportunity to talk it's really fun.
Well, I love that. And we actually went to school together. We've been out of school the same amount of time, which is crazy.
Mhm.
Today we're going to talk about female autism or autistic clients. I don't even the best way to say it. So lately in the field, there's been more talk about females undiagnosed with autism in adulthood discovering that they have autism. And we talk about it a lot in our office. So I think originally when we would talk about it, what were your thoughts? What would you think?
Well, so I've been with KDH 2 years now, I guess maybe 2.5 years. And when I started going to the all clinician meeting, I noticed there was a lot of specialty in autism, which is awesome. But I didn't really think it related to me and the kind of work that I did. I enjoyed listening to the discussions, but to me, autism it's identifiable. I mean, you can see it. I mean, most people get identified as children, and so when you get into that kind of work, you know ahead of time that they have the diagnosis, and so it didn't seem like an area of growth or an area that I was going to get into specializing in. So it was nice to listen to, but I just didn't think it related to the work that I was doing. Yeah,
And
initially.
so I know initially, and this is why I'm excited, right? Because that's changed. So, what is your perspective now?
Well, it was almost like through osmosis that, as I was listening to you all talk, I started to consider it, right? I'm an open person, right? I very rarely have a very closed way of thinking. But I also supervise interns. And so as I listen to my client or my interns talk about their clients and describe their clients, it's a different way of thinking versus having a person sitting in front of you. So in my work, I get the opportunity to listen to a case study where clinical criteria is described to me. And then I get the opportunity to sit in front of someone where they just are themselves in their full capacity. And so it was really in listening to my interns describe cases that just didn't make a lot of sense to me. And it was primarily the first few were women that I said to them, I was like, have you had any, ideas or thoughts about testing them for autism? And then my interns would say, "Oh, now that you mention that, yeah, her twin brother's has autism." Or, "Oh, now that you mention that, yeah, all of her aunts have autism." Right? It was like, and I was like, "Wait, what?" I would mention this one key phrase and my students would then lend a little bit more information that would support why a diagnosis could be possible. But I think even at that time I wasn't fully convinced. It was just me exploring with my students the idea that, some of their clients could use another assessment, another evaluation. This was still academic, right? This was still, let's look at the criteria. It was on paper. They were giving me clues that didn't seem to add up to a diagnosis until I started seeing it and applying it to my own clients that I had that moment where I texted you and said, something weird is happening. Why is this happening? What is going on? I'm 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 seeing it everywhere now. Yeah.
No, you can't. I say you can't unsee it. Once you see
And
it, it is crazy. And then I'm like, I know that we have the tendency to over-identify it, right? So probably some of the people aren't going to have the full criteria to meet the autism diagnosis. But what are the traits that you're observing that you now look at through a different lens?
so the traits, the two that stick out to me the most are high sensitivity. High sensitivity to sounds, high sensitivity to light, high sensitivity to stress, interpersonal stressors. Um, in addition to the way that they cope. So when I'll say, in high stress situations, how are you coping? And it is things like they have to, drown out the sound by being completely in the dark, isolated under covers, this complete escape from senses or, reduction in the senses or a sense that they need to rock, when they're in an intense environment, an intense situation. And none of these things would have entered into our dialogue. It just wouldn't have unless I put on that hat and said, what is it like for you when you have too much light? Can you talk to me a little bit about, your relationship with sound? So unless I use that idea that this person might have autism, I don't know that these conversations would have come up organically. Or they would have, but it would have taken a lot longer. Let's say that, rather than considering it upfront and early.
I think that's such a, like the way you've said it is such a teacher way to say it and such an important perspective, right? Because you've described it perfectly. Like, if you don't have this theory and know what to ask,
Hmm.
they're not going to tell you that light bothers them.
Hmm.
It's just a different way for you to start looking at their mental health and what's
Hmm.
actually probably, I don't want to say at the core of their mental health, but really a big contributor.
Hmm.
Um, so for me, it was I would be in trauma groups, right? And they're like, there must be a trauma history. There must be an extensive trauma history. And sometimes there wasn't. And the
Hmm.
go-to in the groups was like, well, they just don't remember it. And I'm like, why is that our go-to? It is possible, but instead of what else could be contributing so significantly to their mental health that they're like traumatized by very minimal stimuli,
Yeah.
right? Like in an environment that shouldn't be this dysregulating, they are highly dysregulated. I think that that's for me when I started like, whoa. And then it just, if you can purposely ask the questions, it opens up their neurology or understanding their neurology in such a more useful way.
Hmm. I think something that scared me about exploring this with my clients is just my own lack of knowledge. I'm not a I'm not an ABA. I'm not, a trained specialist. I'm not an occupational therapist, right? And so I thought, well, what am I going to do if they actually say yes? What kinds of questions do I need to know? Where can I get, And so that wasn't a good enough reason not to do it. So I kind of stepped into it with just the minimal knowledge that I learned from you all in the meetings and then, a training that you all put on and said, I'm gonna try this. If worst case, I'm gonna refer to a higher level of care for, a more authentic diagnosis. And so yeah, it was just my own reticence because of that training being so specialized. But I'm really glad that I'm invested in this process because I really think my clients, interestingly enough, embrace it. When I say these kinds of things to them, none so far have said, oh, or have been shocked. They seem to think, okay, all right, there's something here. And so I'm not getting that negative feedback that people might assume they would get from their clients. So that's not a barrier anymore either.
It's interesting. I because I've been doing it so long, right? I remember
Mhm.
in the beginning, I was like, should I tell him I think it might be autism, right? Like I almost thought I was damaging them by even saying it. But you're
Right.
right. Most of them were so dysregulated and had so many mental health issues that when I gave them this diagnosis, it actually made more sense to them.
Mm-hmm.
It explained something about them that they didn't understand completely. They knew they were different, but they didn't know why. It's just such an interesting and they weren't against the exploration, right? Because I'm not diagnostically, I can't diagnose them. You're a PhD, so you can't either.
No. You have to have specialized training to do the assessment and get paid to interpret it.
Yes, and we do offer that at the office now, which is kind of fun. But I think like just knowing that we can suggest these things for their own like well-being for them to take ownership of their mental health and try to get a deeper understanding of what's going on inside of them.
Hmm. Yeah. I, I'm trying to think, I'm still new, but looking at maybe some of the patterns that I notice when that one's still hard for me. I still sort of think um, when someone describes themselves as feeling like they're different or like they're an alien or like nobody gets them, that perks my ears up. And then the one for me that's recently come around are women in particular describing their heightened emotional state at the end of the day. So it's not just, oh, I feel so stressed out, I want to have a glass of wine. It's, I know that I'm going to have a panic attack at the end of the day. And it's just a matter of how bad my panic attack is going to be. Or I'm going to be highly suicidal when I get home. And that's just my norm. It's like this super duper intense heightened emotionality at the end of a day where I sort of think, is that, some sort of sensory overload that is related to, you know, the spectrum? I don't know. But those two things in particular get my ears perked up for a further evaluation.
The other ones, because I love that you said that. I have another random one. I had one client, it's actually a friend, but they would have arguments with their husband in the afternoon following kids in the car. So all day at work, kids in the car, they're being a good mom, kids are wild, because we're not watching like a iPad or anything like that. Very engaging, could hold it together, but then they would come in the house and like husband ask a question,
Yeah,
like an anger outburst, right? Like an extreme emotional response. And it was due to the sensory overload. And they were just like, it was just too much.
yeah,
Um, that also chronic suicidality
yeah, yes, yes.
as another, yeah. What are some
Which
other
is,
ones?
which is really interesting, the chronic suicidality, because you don't associate that with autism. It's just it's yet, right? Or at least the emerging research, which is that emotional component. Yeah, it's still developing for me to understand the lack of trauma too. That piece that you said in that trauma group where they seem to have all of these super heightened emotional responses, the hyperreactivity, maybe the avoidance, but there are no memories of a trauma, and we can't seem to figure it out. It doesn't match PTSD. I think that's also one that gets my ears perked up. That absence of trauma, and yet it looks like BPD.
Yeah, or highly, that's another one we can talk about. Yes,
Mm.
BPD are highly disassociative type of symptoms, right? So like, and you're scraping their history to try to see like, could a subtle misattunement from a parent cause this level of
Yeah.
shutdown? Like it just doesn't fit, right? You expect certain things when you work in trauma, like symptoms connected to certain types of traumatic events.
Well, I would oftentimes say, it sounds like they grew up in an invalidating environment. That must be what it is. And that's how I sort of justified the BPD. That must be it, right? Because it's an invalidating environment, but it wasn't yeah, it just wasn't, just didn't fit. It just didn't fit.
And that I think is a really important clue when it doesn't fit. What else could it be? Because I think, up until probably a couple years ago, if it didn't fit, I tried to fit the client into the protocol, right?
Right.
And now I'm like, okay, what else? What else? What else? I'm looking for more. And when you say BPD, we're talking about borderline personality disorder.
Correct.
There is a lot of overlap between female autism and borderline personality disorder.
Yeah. Yeah. They're both lifelong, right? They're both chronic. Yeah. Right. But to me, borderline personality disorder almost always comes with some level of trauma or a really highly invalidating environment. Um, and so yeah, that's one of the clues. If I don't see that, I have to wonder what's next. But like I said, I would never have said what's next. Let me look at autism until, probably, 6 to 8 months ago. Seriously, I would think, what's next? How do I fit my client into this diagnosis? Right? Um, yeah. So,
It's because I
but
think we work, yeah, we work from what we know.
yeah.
I mean, it's not, I don't think we're trying to be malicious to our clients, but no one ever proposed it could be this. I thought it was the white little boys, that the research is based on, lining up things, the traditional forms of autism that
Yeah.
you
Yeah.
expect. I didn't think my best friend, right? I didn't think, sometimes I wonder about myself because I relate to these women so much. I'm like, oh, uh, do I? I mean, maybe.
Hmm.
Um, the rigid adherence. This is another one that I've been like really exploring when they have their rule bounds or they have this like rigid adherence to rules and it's not flexible. Because I
Hmm.
think a lot of us have some flexibility in rules, but this type of neurotype, it doesn't. It's a little more rigid. And
Hmm.
rigid, saying that word, it's so judgy sounding. I think they like routine. They like consistency, knowing what is coming ahead of them. So
Hmm.
extreme anxiety if they can't plan something out. Even parking in a parking lot they don't know can
Mm.
trigger anxiety. It's a really, yeah.
That's
Super.
interesting.
I
Yeah.
know. I
And the
know.
and the overlap with OCD, right? Just, the co-occurring disorders, not just eliminating autism because you've noticed, OCD, right?
I love that. Well, because it does have a different flavor.
It does. Yeah.
There's a different, like even OCD in autism is slightly different. Um, it's like more stubborn. I don't know. It's really interesting. I'm like, you might not get them to totally adhere to an ERP protocol. But
Hmm.
I think this brings up another idea for me is that when I'm helping them, some of the things that are tools I would normally use will
Hmm.
further increase masking, which is like a double sort of whammy on their nervous system. So like I'm trying to think like some of the DBT skills are if it's not working, I'm like, this might be too much, right? I might
Yeah.
need a different skill.
Well, the radically open DBT is in response to that rigid,
Yes.
over-controlled type of client who doesn't respond, or maybe will start masking some of their uh, maladaptive behavior with other behaviors. And so that radically open DBT gives you other opportunities to apply skills that aren't so rigid.
But even then, some of the ones are so like I'll do some of the skills in there because I started the training on that.
Mhm.
Um, finish it, but I'll do some of the skills in it, and some of my clients don't get like a feedback from it. And so
Yeah.
I abandon them. We'll do them for a good 2 weeks, and then I'm like, okay, let's just move on. Um, so it's an interesting. I don't know. It's just interesting to try to figure out what's the best solution for them. And again, to stay open if it's not working. Is it because it's making them mask more? Is it because this just isn't the right skill? Um, yeah, I go in so many ways. Yeah.
Right. So the radically open DBT really relies heavily on cognitive reframing. I find there's a lot of written, write out your thoughts. The aim of it is to increase vulnerability the vulnerability piece is what's supposed to open the client. So it's radically open. So increasing opportunities to be vulnerable, which I love, is not always the right fit for someone who has autism. But I'm still, like I said, I'm still exploring this. So I really don't know what'll work. They're all individual.
I'm with you on that. And I think the experience, I look at it as like the sensory experience of vulnerability
Hmm.
is too much for some people with autism because it's like it literally feels too much. Um, and so you're kind of working, you could be working against yourself, but that's a whole different, yeah. I think just staying open.
Hmm. And individualized to what works for them. Sometimes it's just awareness as well. And working with the sensory overload piece is where I've been getting a little bit of traction, asking my clients to consider ways to reduce their amount of sensory input when they can, just to sort of explore how that might be impacting them, right? Just with a sense of curiosity. What would it take to reduce your amount of sensory input? Yeah.
I read somewhere like an hour and a half break a day, and my clients laugh at me. Um, but when they have chronic suicide, not chronic, well, chronic suicidality, yes, but also like treatment resistant depression,
Mm.
I am like, let's just try to get as much relaxation time as we can, like a sensory break, no lights, no sound, and let's see what impact it has on your mental health.
Mhm.
It's an interesting, when I read it, I was like, no one's gonna do an hour and a half, but it's a good goal.
Well, that brings me to, one of my interests, which is the mindfulness-based
Mhm.
therapies, right? Where I think going back to some of the earlier trainings, it was 45 minutes a day. It was 45 minutes a day. And I still am a proponent of that kind of just allowing senses to come in without being sort of bombarded by so many, right? Just allowing whatever is here to be here. Um, but that may not be right for everybody. I'm still exploring that as well.
Well, and I could see how, like, with the right, I like pairing them. So, like, in a dark room, no sound,
Hmm.
right? Like you would pair it in a different way with mindfulness to see if it had like a positive outcome for them, and positive might not be the right word, but some sort of relief.
Hmm.
So I am really excited. Thank you for joining us today. We could totally talk about this all day long. I love this.
Yes.
I feel like we turned you to our side, not on purpose.
Really, it was my students think I'm some kind of, I don't know, wizard or like a mind reader or so. They would all look at me as like, how are you doing this? They- you know, so my reputation was improved because they just thought that it was um yeah, I was some kind of soothsayer or something. I don't know. Um yeah. So thank you.
Oh,
Thanks for
I'm
bringing this to my awareness.
only because you were open. So
Yeah.
more to come as we try to figure this out. Yeah.
Good. Looking forward to it. Thank you.
Thank you so much for joining us for this episode of Leaning into Therapy. If you'd like to follow along, you can catch our other episodes. You can also find more information about us as a practice at kdholmeslpc.com. Hope to see you soon.